Hello and welcome to this session, dear brothers and sisters, where we're going to discuss the topic that is going to be revolving about deep venous thrombosis. The one who is presenting is Dr. Manirachiza Robert. I have been compelled to record and share this video in as far as this topic that has become actually viral over the past few weeks. My dear brothers and sisters, wherever you are, I welcome you and I beg and kindly request that you watch and follow carefully. Because the information that I'm going to share in this topic is very, very paramount. A few weeks ago, as I can say that for quite some years, we have been losing very many prominent people in our country, and most of them succumbing to blood clots. Blood clots, yeah, that the person got a blood clot and he or she died. Well, it is true, blood clots always kill people, not only in Uganda, but in various parts of the world. So I became perplexed when I was reading on various social media platforms when many of our fellow citizens were saying that blood clots do not kill human beings. That blood clots do not kill human beings. I'm not recording this video for the purpose of politics. No, let us obey and follow science, and we put politics aside in this case. So it is purely about science. I want to unravel to the fellow ladies and gentlemen who do not understand this science, who still don't believe that blood clots kill human beings every day and worldwide. This is the chance for you to get detailed information from a qualified medical doctor who knows at least the science. This time we are not discussing politics, we are discussing science. So let us begin with our chapter, and we see what happens, we see how the events unfold one by one until blood clots form to cause the death of a human being. So my dear brothers and sisters, as you can see, the topic of today once again is deep vein thrombosis, which is abbreviated as DVT. And the presenter is Dr. Manirachiza Robert. And before we start, I need to remind each one of you, my dear brothers and sisters, and request you humbly that don't forget to subscribe to our YouTube channel, Medicentia, with the motto, limitless knowledge. So, as you know, let me begin from our primary school science. I think P4 or P5, yes, primary 5 science. We are taught about the circulatory system of a human being. And in the circulatory system, we are told that the heart is the main pump that pumps blood, yes, that pumps blood all over the body. And the pump, which is the heart, is connected to the pipes, and the pipes that the pipes that we are going to talk about in this case are the blood vessels. The blood vessels, which are further categorized or grouped into three categories mainly. We have, and here they are. We have the veins. The veins which drain blood from body extremities back to the heart and to the lungs for oxygenation. Then we have the arteries. The arteries are the pipes or the blood vessels responsible for transportation of blood to various parts of the body. Then we have also the capillaries. The capillaries are the small blood vessels which are responsible for exchange of materials between blood and the tissues. And the capillaries are usually between the veins and the arteries. Now in this case, we are looking at the veins, and particularly the deep veins. As you can see, still, I can say that the study of that medical science, the study of medicine indirectly started way back in primary school. I think it was in some primary schools, they cover human circulatory system in P5, and other primary schools, it is studied or covered in primary 6. Then secondary school, senior 3. Then in senior 5 also we are taught again circulatory system, and also at the university when we are covering histology, when we are covering physiology, when we are covering anatomy, we also had to look at advanced details about human circulatory system, or the human circulatory system, or the cardiovascular system. Now let us go. We have our deep veins. Deep veins, as you can see, are blood vessels that are deep in the muscles. They lie deep within the skeletal muscles. This time I'm talking about the skeletal muscles, not the smooth muscles. And they're responsible for returning blood back to the heart. As you can see, we have the superficial and deep veins, as we are going to see. But the center of our focus here is going to revolve and is about the deep veins. So, the deep veins. We have the superficial veins and the deep veins. So, what is, I think at this point, you already know the meaning of a vein. A vein is a blood vessel that returns blood, that drains blood from the extremities back to the heart. And all the veins, let me remind you, our science, all the veins transport deoxygenated blood except pulmonary vein. It's only a pulmonary vein that transports oxygenated blood. And the rest, 99.9%, transport deoxygenated blood, blood without oxygen. So, let's look at thrombosis. Thrombosis means the formation, actually it comes from it's a Greek term. It's a Greek terminology that refers to a blood clot formation, and it occurs in one of the deep veins. Of course, I'm not saying that in medicine and generally in medicine we don't say that never. Blood clots commonly occur in deep veins. However, they also occur in the superficial veins, and of course other blood vessels like the arteries as well. So thrombosis, as I'm reminding you, it comes from Greek language and refers to the formation of a blood clot. So thrombosis means a blood clot that occurs in one of the deep veins. Superficial veins, as you can see, they drain into the deep veins, and the surrounding skeletal muscles keep on pumping against these deep veins to push the blood forward and back to the heart. Remember, veins have one-way valves that help to prevent the backflow of blood. For example, skeletal muscles like the calf muscles or the gastrocnemius in anatomy, the calf muscles, you know, those huge muscles at the posterior aspect of the tibia or the leg, those calf muscles or the gastrocnemius, they act as they keep on pressing against the deep veins, and hence enabling to push blood forward from the lower extremities back to the heart. And in our physiology, those of you still call that physiology, or in year one medicine and the surgery classes, MBCHB1, you will remember we are told that the calf muscles act as a set of the second hearts. That's why when you look at the soldiers, when the soldiers are standing upright at the parades, they are advised to keep on actually stretching and exercising their muscles, making them tight tactfully, so that of course you don't become unstable. But they are always advised to keep on relaxing relaxing and contracting some of those skeletal muscles, especially the calf muscles, to keep on pumping blood, pressing against those deep veins to enable blood flow, blood return to the heart. So as you can see, we are saying that veins have one-way valves which prevent backflow of blood. So you can look, my dear brothers and sisters, you can have a look at this illustration of a human being. Of course, this is a partial illustration showing us the leg with the venous network, how it connects to the, these are the veins of the extremities. As you can see, we have the left dorsal digital vein, we have the left dorsal metatarsal vein, left dorsal venous arch, we have the left posterior tibial vein, we have the left anterior tibial vein, we have the left small saphenous vein, we have the left popliteal, left greater saphenous vein, of the left femoral. When you look at this course, so this is blood from the foot, for example, flows back as it is going back to the heart. This is its actual course. It goes and goes and goes. This is the femoral vein, femoral referring to the thigh, and here it reaches, actually it becomes the from the thigh, it becomes the left external iliac, then it continues until it reaches the abdominal vein, the bigger pipe, one of the biggest pipes, which is called the inferior vena cava. And it's the inferior vena cava that connects to the heart. So if a blood clot happens to form, as we are going to see, basing on also the factors that induce blood clotting in those blood vessels. For example, if there's a fracture of a bone, maybe in this leg, if a fracture occurs, a bone segment can pierce or injure one of these veins, hence causing a vascular injury or a venous injury. And when the vein has been injured, that is that marks the beginning of the clotting, of the blood clotting or coagulation cascade. So any fracture within the leg or any trauma, it might not only be a fracture, it can be also another, maybe sharp trauma, not the blunt trauma, but especially penetrating trauma. And one of the veins, especially deep veins, happens to be injured, that is enough to trigger the clotting or the blood coagulation cascade. So let us proceed. So this is the microscopic structure of a vein. By the way, my dear brothers and sisters, at this point, allow me to remind you that anatomically, when we are covering our science, when we are covering our medical science, particularly human anatomy and physiology, all the diagrams, in the diagrams or the illustrations, we use the colors that we use, the international colors that are used to describe the veins are the blue. This blue color, in as far as cardiovascular system, blue color represents the veins. Then red color represents the arteries. Now, why those are international colors? You can't, for example, I cannot start saying that veins are purple, that veins maybe are maroon, no. Or that arteries are maybe purple, violet, is that they are yellow, maroon, no. There are two international colors that are used and that are used in the study of the cardiovascular system. The veins, blue color represents the veins and red represents the arteries. Now here look, why so? Why is it like that? Blood that is oxygenated, that is highly oxygenated, is found where? In the arteries. I hope we are together. Blood that is fully oxygenated is found in the arteries, except the pulmonary artery. Except the pulmonary artery. But all the other arteries carry oxygenated blood. And oxygenated blood is bright red. Oxygenated blood is bright red. Whereas the oxygenated blood, which is carried in the veins, with the exception of pulmonary vein, the oxygenated blood which is found in blood, which is carried by the veins, tends to look bluish, cyanosis. Those of you who are colleagues in the profession, when we talk about cyanosis, from the word, from the color cyan, turning bluish color, darker blue. So the oxygenated blood appears darker blue. It is usually darker blue, and therefore that is the basis of blue color being used to describe the veins anatomically, or in the anatomical science. So, my dear brothers and sisters, my dear colleagues, and to my dear followers, let us have a look at this microscopic structure of the vein. Now, this is our pipe, our vein, which has been sectioned and cut or sliced or sectioned. This is the longitudinal section, and this is the transverse section, as you can see. So within this blood vessel, within this vein, you can see we have the smooth lining, and the smooth lining is the one that is called the innermost lining is called the endothelium. The endothelium is made up of also a single cell layer. So, and then this is the endothelium, the one which is looking brown, I mean pinkish. The one which is pinkish, this one is the endothelium. The inner lumen, the flow of this pipe, the inside of this pipe is made up of the endothelium. The endothelium is the inner cement, the inner tile. It forms the inner tiling of this pipe, which is the vein. So generally this big layer, it's referred to as the intima. So within the intima, you can see we have the endothelium, we have the subendothelial layer, we have the internal elastic lamina. Then you also have another big layer which is called the media. The media is mainly made up of the external elastic lamina. Then you can also see that we have the adventitia, the outermost layer. The adventitia is made up of, it has a lot of vasa vasorum. When it is one, vasa vasora or vasa vasorum refers to a blood vessel that supplies a bigger blood vessel. Yes, the heart is the one that pumps blood to all the parts of the body. It supplies blood to all the parts of the body. But remember, the heart also supplies itself, by the way, using the coronary arteries. We also have the veins. The veins that drain the heart are referred to as sinuses. Likewise, the brain veins are also referred to as the sinuses. So the heart also supplies itself, doesn't forget itself, supplies itself using all through arteries called the coronary arteries. Likewise, the big blood vessels are also supplied by blood, by the smallest blood vessels called the vasa vasorum. When there are many, when it is one, it is vasa vasorum. So you can see now, let us not forget these one-way valves as we progress. You can see the one-way valves, all the veins actually have these one-way valves which are unidirectional. So blood flows going to this direction, and this valve opens to allow blood to keep on going forward. Then as blood is attempting to flow back, these cusps that you are seeing of the valves, they keep on preventing the back flow. And for example, when we have calf muscles or those skeletal muscles around and they are pressing against this wall, they keep on enabling blood flow. When the calf muscles, for example, the calf muscles, which are skeletal muscles in nature or anatomically, when they contract and press against this vein, and the vein is going to allow to increase, actually, they are going to create pressure within the vein, and blood is going to flow upwards, going back to the heart. As it attempts to flow backwards, it's these valves that are going to prevent the back flow. So now, all the events, anything that affects this endothelium, this smooth inner lining of the blood vessel, is going, anything that is going to injure this endothelium, anything that is going to cause any trauma, anything that is going to cause turbulence within the endothelium is going to mark the beginning of blood clot formation. Because this is the path of blood. Anything that will stop blood or slow down the flow of blood, and blood keeps on interacting, the components of blood, red blood cells, the platelets, and other clotting factors get a chance. For example, when the blood has been overslowed down and it is stagnating, and the endothelium starts interacting with the blood cells for so long, and the platelets plus the clotting factors, as we are going to see, it triggers, immediately starts triggering the clotting or the blood coagulation cascade. So let us progress. So as you can see, all the blood ends in the superior or inferior vena cava and into the right atrium, then to the right ventricle where it's pumped to the pulmonary artery and to the lungs for oxygenation. So as you can see, deep vein or deep venous thrombosis, which is abbreviated as DVT, mostly occurs in the lower limbs. Mostly occurs in the lower limbs and below the knee in particular. Although blood clots mainly form in the deep veins, they can occur in the superficial veins and other anatomical regions of the body, as we are going to see. So my dear colleagues, my dear brothers and sisters, my dear friends, as you follow me, you can see the course of our vena cava, our inferior vena cava. So the inferior vena cava connects to the heart. It connects to the heart, as you can see, and this is the other big pipe, the other big vein that drains from the lower extremities of the body, and it connects. This is called the inferior vein, and it connects to the right atrium. Then superiorly, we have the superior vena cava, the bigger pipe that connects, that drains all the blood from the upper extremities, from the limbs, from the brain, from the neck, from the chest, and eventually drains from the upper chest, and eventually drains into the right atrium as well of the heart. The right atrium is a chamber of the heart. From the right atrium to the right ventricle, from the right ventricle to the pulmonary artery, from the pulmonary artery to the lungs for oxygenation, as we are going to see. So this is the cause. So meaning that if a blood clot has formed from the lower extremities or from the legs, you are going to see that it's going to come like this, and the end result will end up in the heart. And from the heart, it will end in the right atrium, from the right atrium to the right ventricle, from the right ventricle to the pulmonary artery, from the pulmonary artery to the lungs, where it lodges and it starts causing havoc, and that havoc that I'm talking about, or the menace, is death in most cases. And depending on the size anyway, the size also, the size of the clot or the size of the thrombus matters. When there are many, they are called the thrombi. When it is one, it is called a thrombus. So now let us also have a look at this anatomical structure of the heart. Now this is the left chamber of the heart. The heart, we know we have two hearts that are joined. We have two in one. Now this is the left heart. Now within, you can see the other big pipe that I've been showing you. It is connecting to the right atrium. The inferior vena cava, which is the other big vein that drains blood from all the extremities, it is connecting where these arrows are showing us the flow of blood. These black arrows are showing us the flow of blood. And because the reason as to why this right side of the heart is blue, you already know the reason. Because mainly it carries or the oxygenated blood to the heart for oxygenation. It is on the pulmonary vein. The pulmonary vein. These are the pulmonary veins. They are the only veins which transport oxygenated blood. The rest, which are indicated in blue here, transport the oxygenated blood. Now we have our inferior vena cava and the superior vena cava. The inferior vena cava transports blood, drains blood from the lower extremities, bringing it to the right atrium of the heart. Then the superior vena cava, or the superior vein on the heart, it drains blood from the upper extremities, from the brain, from the heart, from the upper limbs or the arms like that, from the neck like that. And all the blood from the body converges in the right atrium. Then through the tricuspid valve, it is called the tri because it has 3 leaflets, or the 3 cusps. That's why it is referred to as tricuspid valve. So through the tricuspid valve, this blood from the veins is going to end up in the right ventricle. From the right atrium to the right ventricle, and from the right ventricle, it is going to be pumped through the pulmonary valve or the pulmonary vein, and through the pulmonary artery rather, to the lungs. So as you can see, this is this blood vessel branches and goes to the right lung, and this also branches to the left lungs, where blood reaches and is oxygenated. It receives oxygen, and then from after receiving oxygen, it does not come back, of course. It now comes back to the left side of the heart, to the left ventricle, from the left atrium, from the left atrium to the left ventricle, then where it is pumped to the systemic circulation through the aorta. As you can see now, these are the arrows. This pink side or the red side. This is pink, but it's supposed to be deep red. This is the side of oxygenated blood now. Here, this is blood being pumped to the upper extremities. Then blood that is being pumped to the lower extremities passes through this aorta, descending aorta, and passes behind the heart, and this is why you are seeing it. So like that. So now when we start talking about the inferior vena cava, it is this lower vein. Then the superior vena cava, this is the lower vein that both connect to the heart. Right atrium to the right ventricle, then to the lungs through the pulmonary artery. So this is the anatomy, as you can see, the brief anatomy. So the process begins. So how does blood clot formation begin? How does blood clot formation begin? The process begins with damage to the endothelium, which is the inner lining of the blood vessels. Immediately there is a vessel. The moment it has happened, the moment damage or injury to the endothelium of the vein or any blood vessel has happened, there is a vasoconstriction. Vasoconstriction refers to the narrowing of the blood vessel. The way I can get a big pipe, maybe which is rubber or elastic, and I reduce its diameter by contracting it. That is vasoconstriction. When I make it to contract, if this is a pipe, and I reduce its lumen, and I keep on squeezing and reduce its lumen, it means I'm doing what we call vasoconstriction, or narrowing the lumen. So why does this occur when the blood vessel has been injured? It occurs because it enables to limit the blood flow and blood loss. And immediately when that has happened, we see platelets. After the platelets come and they adhere or attached to the blood vessel wall within the inner lining of the blood vessel at the site of the damage. And the platelets end up becoming activated by tissue factor and collagen. These tissue factors that we are talking about within the blood vessels, remember we looked at the endothelium. Let us go back to our vein. When this blood vessel has been injured, the endothelium exposes the site of injury, exposes collagen and also some other components like the tissue factor. Then within the endothelial cells, we also have what we call the Weber-Faraday bodies. The Weber-Faraday bodies contain also other components that accelerate the process of clot formation. The Weber-Faraday within these endothelial cells, the moment they have been injured and they happen to expose collagen and the tissue factor, then we see also other components like the Weber-Faraday bodies, which contain the P-selectin and the von Willebrand factor. You know the von Willebrand factor, you know what it does. So the moment the P-selectin, which is the cellular adhesion molecule, and that is the P-selectin, the cellular adhesion molecule, and the von Willebrand factor, which is found in the Weber-Faraday bodies. When both those two have been also exposed following an injury, the clotting cascade or the formation of blood clot is accelerated. So you know now what we are talking about. I hope we are now moving in the same boat. So as you can see, the tissue factor and the collagen are kept separate from the platelets by an intact endothelium. When the endothelium is normal, or very intact, do not expect the platelets and the red blood cells to keep on interacting freely. But the moment there is damage to the blood vessel, particularly at the endothelial level, within the inner lumen of the blood vessel, and there is exposure of the Weber-Faraday bodies, which release the P-selectin and the von Willebrand factor, plus also other collagens being exposed and the tissue factors. Immediately the platelets actually become activated and they start adhering or attaching onto the wall, and they keep on attracting more platelets to come, and eventually also red blood cells will come and start being attracted and being trapped until we reach a point whereby a fibrin mesh is formed that traps the escape, that prevents the further escape of the red blood cells from the blood vessels, as we are going to see. So then we see that the activated platelets attract or recruit more platelets to form a platelet plug, and this is referred to as primary hemostasis or hemostasis. So these are simple illustrations of the blood vessels. You can see that the blood vessel has been in number one, diagram number one, blood vessel. This blood vessel has been severed. Severing means to cut or to section, to cut. Now you can see this is the flow of blood, the direction of the flow of blood. So our blood is flowing here like this. It is being lost. Now, in the illustration number 2, you can see at the site of injury where the vessel has been severed with subsequent damage to the endothelium or the endothelial lining. Now you can see here platelets are agglutinating. They are clamping onto each other. the platelets are becoming sticky. Platelets, what are platelets, by the way? Platelets are also referred to as thrombocytes. They are the ones responsible for blood clotting. They are the ones which prevent us from losing blood when we have been injured. Otherwise, when the blood platelets fall below the normal levels in our blood, usually, of course, the normal levels, though the normal values of the platelets in our blood, I think yes, 150 to 450 times 10 to power 9, I think, per liter. Of course, we count in hundreds of thousands, not millions. For platelets, we count in hundreds of thousands. 150,000 to 150,000 to 450,000 per liter. That's the normal value of the platelets. Now, of course, because we have the normal sufficient levels here, now we are going to see platelets being actually being attracted by the tissue factor and other components from the site of injury, and they are going to come and stick onto each other or clamp onto each other. And by doing that, we are seeing a platelet plugs being built around the damaged blood vessel wall. By doing that, remember, this blood vessel first underwent what we call vasoconstriction or narrowing to limit the blood flow and reduce the blood loss. And now the platelet plug is also further adding on to keep on cutting off the loss of blood, as you can see. Then in illustration number 3, we have the fibrin mesh. Fibrin mesh, usually it begins as a fibrinogen, which is a clotting factor that is usually flowing within the blood. Now, for this to happen, for the fibrin mesh to start appearing, fibrinogen must first be activated into what we call fibrin to form a mesh, a katimba, a mesh like the wire mesh. Then this wire mesh comes and joins, it is formed together with the platelets, between the platelets and the red blood cells, which are flowing here, and it starts reducing the blood flow and it cuts off the blood loss. Then in illustration number 4, as you can see, we have our fibrin clot that has been formed already. It has already plugged. It has covered our blood vessel that are at the site of injury, and the blood has stopped flowing. So we are no longer losing blood, cutters of the platelets. So here we have a clot. As you can see, we have a fibrin clot, which is a mixture of red blood cells, the platelets, and the fibrin mesh, a katimba, with also other components like the von Willebrand factor, the collagen, like that. So it's a complex of things in a clot. But of course, see, the platelets and the red blood cells are the majority, with the fibrin mesh that I'm talking about. Then in number 5, you can see the clot is undergoing what we call, illustration number 5, we have the clot undergoing what we call retraction. Retraction is occurring. So the clot actually is expanding and again thickening to further close this damaged blood vessel, further cutting off or stopping any loss of blood, further stopping hemorrhage. So this juncture, you now understand the meaning of primary hemostasis or hemostasis. So after this coagulation cascade is activated, clotting factors, mostly proteins that are manufactured or synthesized by the liver, are usually inactive under normal circumstances and flowing with the blood. Our clotting factors, most of them come from where? They are synthesized by the liver. That's why when there's liver disease, any liver disease that is damaging the functioning of the hepatocytes will also manifest with the bleeding tendencies. So most of the clotting factors that we are seeing mostly are proteins in nature, and they are synthesized by the liver, and they are usually inactive and freely flowing with the blood. So coagulation starts when one of these proteins is proteolytically cleaved. Proteolytically cleaved, proteo refers to proteins, then lytic Lysis means to break down, or to break down, or to cut into pieces, to keep on cutting off. Then proteolytic cleaving means to cut off. Now, for example, if I have a bar of soap, maybe let me say white star, blue star, like that. When I have that long bar of soap and I cut it into pieces, it means I'm ready to use it for washing, because I cannot handle a full bar of soap and I start using it to wash clothes. It looks awkward. It is ridiculous. Therefore, what happens to these to these clotting factors? For them to be activated, they must be proteolytically, means they must be cleaved or cut into pieces by certain enzymes or by some enzymatic activity. Cleaving means to cut off a piece. You cut off a piece or you break it off, then it becomes active like that. So that is what I'm talking about. So these proteins, so coagulation starts, or blood clotting starts when one of these proteins is proteolytically cleaved. Then the cleaved protein cleaves another or activates another, and so on, and so on. And the final step is the activation of fibrinogen to form fibrin, which is deposited to form a fibrin mesh around the platelet plug, like you have already seen. So the fibrin mesh is formed around here, the platelet plug, with of course the red blood cells like here as you are seeing. So that is the fibrin mesh that we are talking about. So then the cleaved protein cleaves another or activates, and so on. And the final step is the activation of fibrinogen to form a fibrin, which is deposited to form a fibrin mesh around the platelet plug. So this is what this chain of reactions is what we call a cascade of events. A cascade of events that result or lead to blood clotting. So we can move to the next slide. So my dear colleagues, my dear brothers and sisters, my dear friends, my dear parents, my dear friends from all over the world, you can see this illustration, or this structure is showing us a blood clot. Of course, if you don't know the science, I cannot laugh at you or blame you. When you look at blood, we might think that it's just a mere liquid, which is like water. No, when you actually analyze blood under the microscopic slide, under the microscope, this is what you see. You are going to see blood. This is actually where we are. At this point, we are at the site of a blood vessel injury. As you can see, this dark side is the inside. We are within the rumen. Now we are looking at the rumen, the inside, within the pipe, within our blood vessel, within that small pipe, or the blood vessel or the vein. It's where we are having this blood clot. Now you can see a mass of red blood cells that are clamped together with these platelets. These platelets, and together with also these solitary red blood cells that have not been clamped, that are not part of the clot. So these threads that you are seeing are the fibrin mesh. The fibrin mesh, or the proteinous mesh, that has been formed following the activation of fibrinogen into fibrin, and fibrin, which forms a mesh that forms a complex that has mainly the platelets, the red blood cells, with the mesh itself to form a blood clot. So when this blood clot breaks off, or when the whole of it goes, and it shifts and it goes to the heart, for example, and subsequently to the lungs, we say that thromboembolism has occurred. When it is still attached to this site of injury within the blood vessel, it is a thrombus. When this blood clot is still fixed at the site of still localized at the site of blood vessel injury, it is referred to as a thrombus. Then when it breaks off the whole of it and it goes, or when part of it breaks off and it goes to the maybe heart or any other organ, Antiroge is there, it means a thrombo, it becomes an embolus. We say thromboembolism has occurred. A thromboembolus, a thromboembolism, a thrombus, an emboli when there are many. When an embolus when it is one. When an embolus, when a piece of clot breaks off and it goes to the distant part of the body, or to the heart or the lungs, or the whole of it goes, we say that it becomes an embolus. So we say, hence the term thromboembolism occurs. I hope we are together. So this science that I'm talking about also enables us in our clinical setting, enables us with the doctors, the nurses, the laboratory technicians, and other healthcare workers, especially when we are actually giving medications, especially through intravenous route or the parenteral route. We have to make sure that, especially when I'm giving an intravenous medication, I have to make sure that there's no bubble. There's no bubble within actually the medication that I'm going to inject, because otherwise that bubble can also cause an embolus, and that embolus can cause disaster, which is death. So we also try to make sure that when we are giving a drip, the drip may be a normal saline infusion, or we are resuscitating our patients with the IV fluids like normal saline, Ringer's lactate, dextrose 5%, 10%, like that. We make sure that there's no bubble that is within that infusion. Otherwise, that bubble can also cause an embolus, which can actually result into disaster on our patient. So this is the structure of the blood clot, and at this point, microscopically, we are now inside, we are seeing inside, in the inside of our blood vessel, our pipe, or a vein, and particularly the site of injury where the blood clot has formed. Next slide. This reinforcement, of course, when the fibrin mesh has been formed, and as we are seeing that it reinforces. So that's why we are saying that this reinforcement results into secondary hemostasis or hemostasis, and results into a hard clot at the site of injury. This cascade, I told you that the series of events is also the series of events that result or that lead to blood clotting or coagulation is referred to as a cascade. So this cascade results from a high level of amplification. Means there's amplification of events, and especially the proteins that we saw, especially being cleaved and activated. The way I can get a bar of soap, break, or start cutting it into pieces, meaning that I'm ready to use piece by piece, like that. Meaning I have activated that soap, it is ready for use. We together. So there is a high level of amplification, and takes a few minutes from injury to clot formation. Clot formation takes how many from the time of injury to the time of clot formation? We see that it takes very few minutes. Very few minutes. Otherwise, if a person has blood that does not clot, of course that is also a problem. When blood is referring to clot, it means there's a problem. When blood is referring to coagulate, that is of course clotting. By the way, coagulation, the meaning of coagulation, you know, eggs. If I break a raw egg, it is going, of course, to be semi-liquid, and the liquid, that yellow liquid that you see, is going to start flowing. But when I boil that egg, and I break it again, and I start maybe removing the other calcium carbonate shell, you will see something, the albumin, which is the white component of the egg. Then within the center, we shall be having the yolk. In our local chicken, the local eggs, the indigenous eggs, usually yellow. So within the yolk. So when you boil an egg, it means the albumin and the yolk, they cease being liquid or semi-liquid. They undergo what we call coagulation. So those proteins within the egg undergo coagulation. That's why you just break it and you remove that calcium carbonate shell, and you start feasting. So that is coagulation. So note that coagulation is highly controlled by anticoagulation proteins that target and inactivate key clotting factors. For example, we see antithrombin inactivating clotting factors. This is clotting factor number 7, clotting factor number 9, clotting factor number 10, clotting factor number 11, clotting factor number 12, and the thrombin itself. So as you can see, let me repeat these sentences or the statements. Note that coagulation is highly controlled by anticoagulation proteins. Yes, you have those ones which support coagulation or blood to clot. Then you also have those ones which are anti-coagulation or anti-clotting. Otherwise, if we do not have anticoagulation proteins, we can, or every time we can be dying of blood clots. Yes, so-and-so has died of a blood clot. Dr. Manrachis has died, succumbed to a blood clot. If I'm lacking anticoagulation proteins, therefore we must have a balance. If I don't have them, that will, of course, become a disaster. Then also, if they are too much, again, they can also cause me a problem. That's why we say that too much of everything is always bad. And that's why we say that in the Oriental philosophy, the philosophy of the Japanese, Chinese, the Koreans, we have what we call the yin-yang philosophy. The yin-yang philosophy. Everything must be in balance. When there is an imbalance, there will be trouble. Likewise, when it comes to this hematology or to blood physiology, when there is too much of everything or less of everything or insufficiency, there will be a problem on either side. So note that coagulation is highly controlled by anticoagulation proteins that target and inactivate key clotting factors. For example, we see antithrombin, which inactivates the clotting factors that I have already mentioned. Why, you might ask that, what does this A stand for? This A stands for activated clotting factor number 7, activated clotting factor number 9, activated clotting factor number 10, activated clotting factor number 11, activated clotting factor number 12. So A stands for activated. So the antithrombin is one of those anticoagulation factors that participates in inactivation or disarmament of these already activated clotting factors, especially when they have achieved their role of hemostasis. Thank you. Let us progress to the next slide. So among the other anticoagulants, among the other anticoagulation proteins, we have protein C. Protein C and S, by the way. We have those protein S and C. Now, those of you who are seeing this, who are following me, you can add on protein S. Protein C and S inactivate activated clotting factor number 5 and the activated clotting factor number 8. As the clot grows, and as the clot grows, of course, they have names, and we are going to look at those. We are going to have a review of the names, the specific names of these clotting factors. So, as the clot grows in size, it limits blood flow and increases pressure in the vein. Usually, the clot starts disintegrating naturally. For example, protein plasmin, which is an enzyme, breaks down fibrin into what we call the D-dimers. D stands for the proteins, the byproducts of breakdown of the other fibrin mesh and the other proteins. So the D-dimers. So the protein plasmin, which is an enzyme, breaks down the other fibrin mesh into D-dimers, especially when the clotting is no longer needed. When the blood clot is no longer needed, when the blood vessel is healing, actually normally, when no more blood can be lost through the defect. So our protein plasmin comes in to break down the other fibrin mesh. The wire mesh, I can relate it to a wire mesh to form what we call the D-dimers. By the way, in our laboratory, in our pathology lab, in our pathology laboratories, particularly hematology laboratories, we use the D-dimers in the diagnosis of DVT and other blood coagulation disorders, whereby there's in any condition where there is increased the presence of blood clots in blood, we measure the D dimers. When they're elevated, that is a sign that, oh, there is a clot that is present, or clots are present within the saturation. So not carefree here, not carefree here. Sometimes a big chunk of the clot breaks off, and it forms an embolus, which I have already explained. It forms what we call an embolus, which flows with the blood to the heart, and when this happens, it becomes the thromboembolism. So the thromboembolus reaches the right atrium to the right ventricle, then pumped to the lungs, where it gets lodged to cause what we call PE, pulmonary embolism, which is abbreviated as PE. This is a life-threatening condition because it blocks blood from reaching the lungs for oxygenation. Sometimes an individual might be having an atrial septal defect, an ASD, so here the blood clot can cross to the left atrium, bypassing the lungs completely, and unfortunately this clot ends up in the left ventricle and is pumped to the systemic saturation, then to the brain, blocking blood vessels and causing what we call an embolic stroke, which is also a form of an ischemic stroke. When we start looking at the types of strokes, this embolic stroke is a form or a type of an ischemic stroke. So what am I talking about? What am I talking about? Let me go back to our structure of the heart. Look at this anatomical structure of the heart. When someone is having an ASD, an atrial septal defect, an ASD, meaning that this septum, this middle wall that divides the right heart from the left heart, so within this region, we can be having an opening that did not seal. That opening is the one that is forming a channel or a canal that is making this right atrium to communicate with the left atrium. So in this case that I'm talking about, a blood clot might not go if that individual has an ASD, an atrial septal defect. In most cases, they are usually congenital. Yes, they are usually congenital. And in some individuals, they are detected when they're already old, by the way, when they're already mature, when they're already adults. So, meaning that instead of the clot going to the lungs, it will just come and use this defect and cross over and ends up in the right atrium, then into the left atrium rather. Then to the left ventricle, then from there it is pumped. It is pumped to the systemic saturation, and if it goes to the systemic saturation, let me say pumped to the head, and particularly it ends up in the brain and blocks one of the blood vessels. That's when we are going to end up with an embolic stroke, which is a form of an ischemic stroke. Then now we can go back to our illustration. So we have already seen. So if that clot has passed through an atrial septal defect and ends up into the systemic saturation, it is going to end up in one of these blood vessels, blocking any of the blood vessels in the brain, in any of the arteries, and that's how we end up with an embolic stroke, which is a form of an ischemic stroke. So this is the structure of the heart and the lungs together. So this is the anatomy they are showing us, how the heart is embedded between the right and the left lung. So this is our inferior vena cava, as you can see. Then this is the superior vena cava. They all converge at the right atrium into when blood is flowing, it flows, or when the clot is flowing with the blood, it goes from this right ventricle to the pulmonary artery, from the pulmonary artery to the lungs for oxygenation. Then when the clot reaches somewhere here, it blocks around the lung, within the lungs or the junctions of the lungs. If it is big, it blocks, cuts off the blood supply to the lungs, meaning more blood is not going to reach the lungs for oxygenation, and that causes what we call pulmonary embolism. And pulmonary embolism is fatal. It is a disaster. It is the one that causes death. When you hear that, oh, a person has died, succumbed to a blood clot, usually, in most cases, the blood clot has lodged around within this region, around the lungs, and death occurs like that. Of course, from hypoxia, from anoxia, because if blood is not reaching the lungs to be oxygenated, what follows? It means there will be hypoxia, then anoxia, and when the body is deprived of oxygen, there will be death. As simple as that. So, now, my dear colleagues, my dear brothers and sisters, my dear friends who are following me, let us look at the factors that lead to deep venous thrombosis. Now, here we come. We are going to look at the virtuous triad. Virtuous triad. Virtuous is a human being, by the way. Virtuous was a human being. Virtuous is the name of a human being. He was a doctor, actually. I was called the Rudolf Virchow. He was a specialist doctor, a specialist physician. He was a pathologist. He was a German pathologist who is the one who first described this triad of blood clotting in the year 1848. He was a German pathologist. Virchow, he was called Rudolf. He was called Rudolf Virchow. Rudolf Virchow, and he was a German pathologist, physician pathologist, or a specialized doctor at the rank of, he was a pathologist. He was the first doctor to describe this triad. However, some sites, some information, medical literature, medical history tells us that he did not actually describe it fully. He did not describe it completely, though it was named after him. He described, I think, two events about hypercoagulability and I think circulatory stasis. But I think vascular damage was described by another pathologist, this time from France, in the year 1889. This one was the first to describe. Virchow, Rudolf Virchow, was the first to describe the triad in the year 1848, and he was a German pathologist. Then in the year 1889, the French pathologist described the third, I think, was able to complete the triad. And he was called Dr. Who, that pathologist was called Dr. Troisier. Charles Emile Troisier. He was also a pathologist. So those two are the ones who first described the triad. But the pioneer was Virchow, Rudolf Virchow, the German. So now, these are three factors that we are going to look at the triad, a triangle. From when you look at the triad, a triangle. That's why you are seeing a triad here. So triad number one, we have the circulatory, we have the hypercoagulability of blood, or hypercoagulation of blood. Hyper refers to high, then coagulation means to clot or to form clots. So hypercoagulability of blood. Hypercoagulability of blood. So triad under triad number one, we have hypercoagulability of blood. Increased means increased, the hyper means high, or increased. Increased the tendency of blood to coagulate or to clot. So under this, we have the factors which contribute to hypercoagulability. We have inflammatory bowel disease. Bowel refers to the intestines. This is a condition that affects the bowel or the intestines. So inflammatory bowel disease. We have autoimmune conditions like autoimmune conditions like thrombocytopenic, idiopathic thrombocytopenic purpura. Yes, is one of them. I think Aldrich-Wiskott syndrome, if I remember well. Aldosterone syndrome? No. No. Then we have estrogen therapy. Estrogen, this is the hormonal therapy. Estrogen is a hormone, mainly a female hormone. Then we have inflammation of the blood vessels. Inflammation of the blood vessels. What is inflammation? Inflammation is the process. It is an immunological reaction whereby the white blood cells are attracted to the site of injury, the site of inflammation, the site of infection within the body tissue, within an organ, and when the white blood cells gather with other components and they start releasing the magic breaths, the cytokines coming in, causing more damage to the tissue. That is when we say that there is inflammation. We can't say that there is inflammation without white blood cells being attracted, without cytokines, and without, of course, swelling. There are components of inflammation. We have swelling, we have reddening, we have loss of function, we have reddening, and heat or increase the temperature. So in Latin, they come from Latin. Dolor, pain. Calor, heat. Rubor, red. Then tumor, swelling. Function, lesser. Loss of function. So, but in most cases, we go with the four. We don't include loss of function. So then dehydration. So these factors, as you can see, they contribute to, they increase dehydration. When you are not taking enough water and your body is lacking water, and you are in a dehydration state, so your body has a tendency of clotting, so the blood is hypercoagulable. So number two, factor number two, we have also others, like major surgery or trauma to the blood vessel, malignancies. These are cancers. These are cancers. They also increase the hypercoagulability of blood. Pregnancy, especially during the postpartum. You know, in the pregnancy, there are clotting factors that increase, and others, especially the anticoagulation factors, decrease. That is the disaster. Pregnancy also. Pregnancy is good because it brings a lot of good things. All of us are byproducts of pregnancies, but it also has the negative side. So there are some clotting factors that increase in pregnancy. So my dear colleagues, we also have inherited thrombophilias. They also contribute to hypercoagulability. Then infection and sepsis. Infection by some bacteria will also cause the hypercoagulability of blood, and the sepsis, of course. Then we can now look at circulatory stasis. Circulatory stasis refers to immobility. Circulatory stasis can be caused by immobility. When I sit for so many hours, like 8 hours, 7 hours, 5 hours, 5 to 10 hours without moving, it means I've been immobile. For example, some of us can travel for longer distances in aeroplanes for many hours, 16 hours, going to the US. We can sit in the buses, traveling maybe from Kampala to Chisoro, from Chisoro to Kampala, from Kampala to Guru for 6 hours. All those, that is immobility. That immobility, when someone is bedridden for some days, that is also an immobile state. And that person is at risk of blood stasis, or having his or her blood stagnating in the blood vessels, or flowing much slower than normal. So we also have venous obstruction. Like, for example, in obesity, people are extremely overweight. In tumor cases, some tumors, cancers, in pregnancy, we also have circulatory stasis. Then varicose veins, you know those people who have tortuous veins that can be prominent, especially within their calf muscles or beneath their skins. You see veins actually which are super coiled like some snakes or like worms. Those are the ones we are calling the varicose veins. Then conditions like having atrial fibrillations or left ventricular dysfunction All these can cause circulatory stasis or stagnation of blood, or reduce the speed, reduce the flow of blood, reduce the speed. Then we'll have congenital abnormalities affecting venous anatomy, maybe Maythana and the Paget scrota syndrome, like that. Then low heart rate or bradycardia and low blood pressure or hypertension. All those trigger or cause circulatory stasis or stagnation or reduce the speed of blood flow. Then the last factor under this vicious triad, we have vascular damage. Vascular refers to the blood vessel or the vessel damage. So under vascular damage, we are going to see that we have the thrombophlebitis. Thrombo means a thrombus. A thrombus causing also thrombophlebitis. Phlebitis refers to inflammation. You already know the meaning of inflammation. Phlebitis refers to inflammation of the vein. So thrombophlebitis, presence of a thrombus and also with inflammation of the vein will cause of course vascular damage, thrombophlebitis causes vascular damage. Psoriasis is a condition that is commonly occurs within the subcutaneous tissues, resulting from bacterial infections, especially the staphylococci, streptococci, especially the group B beta hemolytic. Those ones cause psoriatis. Of course, we also have others like strepiogens. We have Clostridium perfringens. All those cause psoriatis, Pseudomonas aeruginosa. Back to our microbiology of particular bacteriology. So we have atherosclerosis. Atherosclerosis also causes vascular damage. Atherosclerosis is the formation of, for example, when the fatty plaques accumulate to form streaks, and eventually that become streaks. Those fatty streaks that broke or reduced the lumen of the blood vessel. When those fatty streaks have formed the plaques, we say the blood vessel has undergone what we call atherosclerosis. The cholesterol has formed atheromas. Of course, cholesterol is a form of a lipid. So we have indwelling catheters and the heart valves. All those cause vascular damage. Then vein puncture. When we use cannulas to prick the vein, when we do vein puncture or we puncture the vein or pierce the vein, when we are administering some drugs or when we are drawing blood, maybe blood samples for laboratory diagnosis, this is what we are calling vein puncture. Then physical trauma, strain or injury to the blood vessel will of course cause vascular damage, and particularly what is undergoing damage, it is the endothelium. The endothelium is the one that is being damaged. Now, we also have microtrauma to the vessel wall, particularly the endothelium. So my dear colleagues, this is in summary, this is the vicious triad. So the vicious triad has three components: the hypercoagulability. We have seen the causes of hypercoagulability or the risk factors of increased the coagulability of blood. We have looked at the vascular damage. We have looked at the circulatory stasis. Then now let us pass through very fast. Number one, let us begin with the circulatory stasis or stasis of blood or stagnation of blood or reduced blood flow. We have seen the factors that reduce blood flow or that causes stagnation. This is slowed blood flow or stagnation. Yes, in the normal blood vessels, blood flows smoothly, but in conditions which cause turbulence in the vasculature, side pouches and pockets are formed, causing some blood to stagnate, which is stasis. And stasis also occurs due to factors like inactivity of the skeletal muscle pumps. Of course, the second hearts, the calf muscles, the gastrocnemius. Like in cases of prolonged bed rest, for example, when someone has been bedridden for so long. So long flight hours, those of us who enjoy aeroplanes, who like being in aeroplanes, so long flight hours Car travels for longer distances and many hours, and during pregnancy, some hormones, of course, cause elevation of clotting factors, like factor 1, clotting factor 1, 2, 7, 8, 9, and 12, with reduced anticoagulation proteins like protein C, S, and antithrombin, with the resultant inhibition of fibrinolysis. During stasis, platelets plus clotting factors come into contact with the endothelium, and prolonged interaction leads to adhesion or attachment, which triggers the activation of the clotting cascade. So, my dear colleagues, let us first review the names of these clotting factors. You may say that clotting factor Roman numeral 1, Roman numeral 2, 7, don't they have names? So let us recap. The clotting factors have the names. Clotting factor number 1 is referred to as fibrinogen or fibrinogen. Clotting factor number 2 is referred to as prothrombin. Clotting factor number 3 is referred to as tissue factor or thromboplastin. Clotting factor number 4 is referred to as calcium. Clotting factor number 5 is called proachellerin or rhabdoid factor. Clotting factor number 7 is referred to as proconverting factor or stable factor. Clotting factor number 8 has about two names. It is referred to as antihemophilic factor A, antihemophilic globulin, yes, that is clotting factor number 8. Then remember, we don't have clotting factor number 6. Number 6 is not there. So don't you say that, this doctor skipped clotting factor number 6. We don't have it. There are 12 in total. We have up to 13, but the 6th is not there. But there are 12. So the second name is antihemophilic globulin, that is clotting factor number 8. Then clotting factor number 9, it is referred to the names. It also has the name. It is referred to as antihemophilic factor B. Then clotting factor number, it also has another name, plasma thromboplastin component. And it is also, 9 is also called the Christmas factor. By the way, I should have begun with the Christmas factor because the name Christmas is simple. Then clotting factor number 10 is Stewart-Prower factor. Clotting factor number 11 is referred to as plasma thromboplastin antecedent. Also known, it also has other names like hemophilia C and the Rosenthal syndrome. Yes. Then clotting factor number 12, it is referred to as Hedgeman factor. Clotting factor number 13 is referred to as fibrin stabilizing factor, or also known as Lucky-Rowland factor. So that is a recap. So in pregnancy, you already know which clotting factors increase in concentration. Factor in pregnancy, you have clotting factor number 1, which is fibrinogen, 2, prothrombin, 7, proconverting or stable factor, 8, antihemophilic factor A. You can, I have already recapped. So we can go to the next slide. Hypercoagulability. Hypercoagulability. There is in hypercoagulability, there is altered amount of clotting factors. Here we see an increase in primary or secondary hemostasis due to elevated clotting factors in blood. This commonly occurs in postoperative patients. Some genetic conditions like factor 5 Leiden mutation, and medications like contraceptive pills. Contraceptive pills are good. Of course, they do out of wonders. They protect us from giving birth like rabbits, rats, but they also have the negative side. Let's not talk much there. That will be a topic of another day. So during surgery, the damage to the blood vessels activates the clotting cascade. So you hear that someone has died following maybe a general surgical procedure, that he or she died. Sometimes they die not because we should not always rush to castigate the surgeons or the one who did the procedure. Sometimes inevitable catastrophes happen. And these are the ones that we are talking about. Following surgery, the surgery was successful. Everything went on smoothly during the intra and post-operatively. Then after maybe 1 day or 2 days, you had a person has died. When the postmortem is done, they find that they maybe succumbed to a blood clot following, of course, pulmonary embolism like that. So hypercoagulability, you can see the factors which you can see, which are involved. So contraceptive pills, as we are seeing, they shift the balance of the clotting factors towards the clotting, like in the case of pregnancy, for example. You know, the hormones, the pregnancy hormones, especially the progesterone and estrogen, those hormones, when we are using pills, especially or combined oral contraceptive pills and other non-orals that are combined, or progesterone only, all those are pregnancy hormones. You know, in pregnancy, a woman cannot conceive because eggs, ovaries are inactive, they cannot release much eggs. So a woman who is pregnant cannot conceive. Cannot conceive. So those hormones are the ones which actually keep the ovaries at bay, inactive without producing eggs. Likewise, these pills mimic the pregnancy state. These pills that our mothers, our sisters, our wives, of course, I'm not saying that all of them. Some use them. Some use them depending on various factors that I don't want to mention here. So those pills that are those contraceptive pills mimic pregnancy state. And in so doing, they also end up altering the clotting factors towards the clotting. So like in the case of pregnancy. So these pills also reduce the concentration of anticoagulation factors or anti-clotting proteins like protein C, S, and thrombin. So let's look at triad number 3. Triad number 3, you can see the damage to the endothelium, which we have already gone through. So we see the damage to the blood vessels, particularly to the endothelium, exposes the tissue factor and collagen. And the damage can be caused by infections, chronic inflammation, toxins like snake venoms, nicotine, and benzopyrene from tobacco that some of us smoke. So I say that when the blood vessel is damaged, the endothelial cells end up actually releasing the Weber-Faraday bodies. Remember, the Weber-Faraday bodies contain the von Willebrand factor, the P-selectin, which is a cellular adhesion molecule, and together with the exposed collagen and other tissue factors, they attract platelets which are activated, then which become activated, then they also end up attracting more platelets like that, hence triggering the clotting cascade. So, as we can see, deep venous thrombosis is common in the lower limbs below the knee. And when it occurs, the area affected shows key features of inflammation, such as pain, swelling, redness, and heat, warm, calorimetry, the study of heat, redness, rubor, swelling, tumor, pain, dolorimetry, the study of pain. So when pulmonary embolism occurs, PE, we already know the meaning of pulmonary embolism when the clot has already lodged within those major blood vessels of the lungs. We said pulmonary embolism has occurred. So when pulmonary embolism occurs, the patient starts experiencing shortness of breath, chest pain, and if the clot is bigger and blocks the main vessels, bifurcating to lungs, death occurs. So how do we diagnose deep vein or deep venous thrombosis? So one diagnostic method number 1 is by imaging. Under imaging, we have the Doppler ultrasound scan. Doppler ultrasound scan, the one that scans the deep veins and the blood clot, the site of the blood clot is able to be detected. Then you also have venography. Under venography, a certain dye, of course a safe dye, is injected within the vein, and then that region, that limb that is affected, is an X-ray is taken. An X-ray of that region is taken with the dye inside. So the dye, which is of course usually becomes opaque, will show the site of the clot, where the clot is, with the vein with the clot. So that is under venography. It involves of course X-ray, as well as of course injecting the dye, like I've said. Then we also have blood investigations. Under blood investigations, we have what we call D-dimers. These are fibrin degradation products from the other wire mesh, from the other protein mesh that is formed at the site of the clot, that is part of the clot. So when the D-dimers are elevated in the blood, it means there's a the blood clot is present somewhere, or blood clots are present. So the D-dimers. D refers, I think, to domain dimers. They are proteins in nature. They are fibrin degradation products. So treatment, but at this juncture, my dear colleagues, I'm not supposed to be giving you treatment, because this is unethical and is unacceptable. Therefore, let me warn you before we go through the treatment modalities. Never try to be clever. Never try to assume to know, and you start Googling and you start challenging the qualified doctors, qualified health workers, that you know, that give me this medication and not this. You'll be causing harm to yourself. Never prescribe for yourself these medications. They are very, very dangerous. They are very, very dangerous. You give yourself a higher dose, death will occur. You die of hemorrhage, bleeding tendencies all over. So don't risk. Don't try this at home. You should try this while you are in the hospital setting, and you should try it in the presence of a specialist doctor, in the presence of a doctor who will monitor you. Otherwise, in other actual videos that I like sharing, I rarely actually give treatment modalities. So as you can see under this treatment, we see that the small clots dissolve on their own by body's natural mechanisms, like we have already seen. So then large blood clots need intervention, and under the interventions we have surgery. This surgery is not carried out by any surgeon. It is carried out by a vascular or a cardiothoracic surgeon, a cardiovascular surgeon or a cardiothoracic surgeon or a vascular surgeon. And the surgery that is done is called the thrombectomy. Thrombectomy is the surgical removal of the clot from the vein that is affected. Then we also have thrombolytic medications. Thrombolytic medications, under thrombolytic medications, we have examples like streptokinase. This streptokinase, by the way, is a toxin that is produced by streptococcal bacteria. Streptococcal bacteria in the group of beta hemolytic group. Streptokinase is an enzyme. We have also urokinase. Streptokinase was discovered in was invented and discovered in the year 1933 by one of the doctors called William. I'm forgetting other names. I think it was a British. Then we have urokinase and streprase. All these are non-fibrin specific enzymes. So they are medications. By the way, streptokinase, surprisingly, I can say that here, sorrow becomes Paul in the Bible. Let me quote the Bible. Sorrow becomes Paul. Streptokinase, under normal circumstances, it is a bacterial toxin which actually keeps on degrading most of our tissues. Our tissues, especially the subcutaneous tissues. And it is involved actually in the pathology of pathogenesis of boils, I think, even cellulitis, even necrotizing fasciitis somewhere. Leave alone the other, the rota, the theta toxins, but also streptokinase is involved somewhere in the pathology of those surgical conditions. So streptokinase in this case, it is not a toxin, but is being used as a thromboritic. A thrombo, by the way, thrombo refers to a thrombus or a blood clot. Then lytic means lysis, bursting, breaking down. So these are medications that break down blood clots. Hence the name thrombolytic or thrombolytic medications. So we have already seen streptokinase, urokinase, and streplase. All these are non-fibrin specific enzymes. So urokinase, by the way, it is an enzyme that follows in the class of, I think, matrix metalloproteinases. Also, some cancers use it during the process of metastasis or migrating or invading other distant organs. That is urokinase, not streptokinase. Some cancers use it. When it follows under the other enzymes, the matrix metalloproteinases or the MMPs, which use, I think, zinc as one of the cofactors. Yes. So we have fibrin specific medications which include and in this class, the first class, we have the tissue plasminogen activators. They abbreviated as the small t PA. Then these examples in this family, we have tenecteplase, alteplase, and the reteplase. All these are also enzymes you can see as. The suffix as, me implying that they are also enzymes. Then we also have long-term treatments which aim at prevention of clot formation. And examples here we have anticoagulant medications such as heparin. Heparin, by the way, it is a glycoprotein what? It is a glycoprotein drug. Heparin, warfarin, the coumarins. You remember the coumarins? Yes. Then we also have other advanced treatments. For example, filter implantation in the inferior vena cava to prevent pulmonary embolism. A certain mesh that keeps on, it is a certain mesh. Of course, it is not a typical mesh. It is implanted or fixed or placed within the inferior vena cava, so that, of course, in a patient who is at risk of getting DVT and subsequently developing pulmonary embolism. So when that filter is placed in the inferior vena cava, filter is placed. So in case DVT occurs and there's a thromboembolism, the blood that has not coagulated, it keeps on passing through. Then a clot remains trapped there, and it is kept at bay. However, the inferior vena cava filters also have negative effects, or the negative side effects, because they increase the tendency of DVT in patients actually, or in so far in patients who have been assessed over the years. So how do we prevent deep venous thrombosis or DVT and subsequently blood clot formation, thromboembolism and pulmonary embolism, those ischemic strokes or embolic strokes? How do we prevent DVT? Number one is to putting on compression stockings. If you know that you have tortuous veins, the other varicose veins, especially in women, they become, actually women with those veins, they become too prominent in pregnancy. Then for us males, we also have many males who have those varicose veins. So if you know that you have those prominent varicose veins and they usually disturb you, you can you can keep on consulting the surgeons, orthopedic surgeons, general surgeons. They can advise you, they can guide you well, and where you can be buying these compression stockings from, so that you don't stand the risk of suffering from deep venous thrombosis. Then calf muscle exercises after sitting for long hours to prevent stasis of blood. For example, when I'm traveling from Kampala to Chisoro, or from Chisoro to Kampala, or from Kampala to Guru, or any other long distance travel, may always endeavor and try, by all means, you should always try to get out of the bus or that vehicle and you just do some jogging. Even if you are jumping, jog, you do calf muscle exercises, you stretch a bit, you stretch the knees, you make sure that you are doing actually some exercises, you move, you run, you keep on flexing and extending your knees like that. So by doing that, you are doing calf muscle exercises. Calf muscle exercises, those are the gastrocnemius muscles. The other ones in my mother tongue we call it ibitega binini, ibitega, not the other bitega in Uganda. That I'm not meaning the bitega in Uganda. I mean ibitega. Ubutega, in my home, actually my home village, some people insult others by calling them Obubugana. Obubugana means puppies. So calf muscle exercises are a must and they are usually very, very helpful. That's why even soldiers who are at the parade, standing at the parade or parading, they should actually, they are advised to keep on, I don't know whether, anyway, I don't know whether they advise them to do so, but they are supposed to keep on doing the calf muscle exercises to prevent actually postural hypotension. Some of them collapse because of poor venous return while they are at the parade. But some of them collapse because of hypoglycemia anyway, not due to hypertension, postural hypertension always. So calf muscle exercises after sitting for long hours to prevent stasis of blood. Then those ones who fly for long hours in the aeroplanes, they will also advise you, if you know that you enjoy aeroplanes, flying for many hours, 13, 16 hours. If you know that you are a person of that type, I kindly request you to be standing up in the plane, you dance, you jump, while it is up in the sky. I advise you to do so because you are also at risk of suffering from DVT or deep venous thrombosis. We call it what? That condition is called what? Economic class syndrome. Economic class syndrome. So Rodose, then also lastly also give Rodose aspirin, especially after surgeries like orthopedic procedures, following orthopedic procedures such as knee replacement surgeries or hip replacement surgeries. We give such drugs, Rodose aspirin. Or also in patients with, of course, cardiovascular diseases, especially heart failure, a certain category we do give them, we put them on Rodose aspirin to prevent this disaster of this time emboli forming. Also use Rodose aspirin to prevent coronary thrombosis. By the way, it is not only blood clots which kill our patients. I also have fat emboli. For example, if a person gets a fracture of the wrong bone, like the femur bone, this is what happens. The wrong bones usually have a fatty yellow bone marrow within the central canal. I'm forgetting the medullary cavity, within the medullary cavity of the bone, or within that marrow canal. When that such wrong bone fractures or breaks, and it ends up injuring maybe a vein, maybe the femoral vein, and it so happens that if certain fragment, a certain portion of the fatty yellow bone marrow enters such a vein, and if it finds itself in the heart and subsequently in the lungs, it causes what we call a fat embolism and also kills. When you hear that a person who sustained a fracture of the wrong bone, any wrong bone by the way, and the fat, it so happens that a fat enters one of the blood vessels, it can cause such a disaster, especially the veins. Then also have, does not mean that blood clots only form in the veins, no. They also form in arteries, the coronary arteries that supply the heart. And that is one of the mechanisms through which we get heart attacks. Ischemic heart, we get heart attacks or cardiovascular accident. You have someone got a heart attack. A heart attack can also be caused by a blood clot or a fatty plaque inducing a blood clot to form in one of the coronary arteries of the heart to cause the heart attack or cardiovascular accident. Are we together? So that is also a form of blood clot. Then also have other vascular arterial conditions like Takayasu. Takayasu is not common amongst we black Africans. It's common in the Asian communities, especially the Indians, the Chinese. Takayasu arteritis. Takayasu is also another inflammatory condition that affects the arteries, especially the arteries of the extremities, the arms, the lower limbs, and it results into formation of blood clots, resulting into paroxysness, meaning that when you palpate maybe the radial artery or the brachial artery, you'll find actually you'll not feel you'll not feel any pulse or any pulsation of that artery in Takayasu. But when you are mentioning diseases, especially to the colleagues, don't always rush to mention those rare conditions. Should begin with the common things, because common things occur commonly. We have reached the end of this presentation. Thank you very much for watching and listening. We link up in the next sub-chapter or the next topic that I'll be presenting in a few days to come. Thank you very much.